Hello, and welcome to the June 2025 Registry Partners Oncology Coding Break on liver and bile ducts, anatomy, histology, and Schema discriminator 1. In this month's coding break, Melissa Metter returns to lend her anatomy and physiology expertise to us once again. So Melissa is going to get us started with anatomy of the liver, bile ducts, and other structures. And then she's going to tell us about the very distinct differences in hepatocytes and cholangiocytes. Next, we'll move to looking at unique to liver and bile duct histologies. We'll determine primary site, and then we'll look at primary site C24.0 and discriminator 1. So with that, I'm going to pass the mic over to you, Melissa.
Thank you, Heather. So we're going to start off and talk about the anatomy of the liver. So the liver is one of the largest glands in the body and is very involved with metabolism. So first of all, this is a model that I used when I was teaching. A is going to be the hepatocytes that are going to be found all over the liver. B is the sinusoids. So some of them are filled, and then also the ones that are empty. C is the bile caniculus. And then here is an intrahepatic bile duct, and we'll talk more about those in a moment. Then this is a branch of the hepatic portal vein and a branch of the hepatic artery. Now, the liver is very involved with regulation of metabolism. The hepatic portal vein receives blood from the stomach, the small intestines, and the large intestines. So if you have recently eaten a meal, this blood can be full of carbohydrates, amino acids, fats that are going to be coming into the small intestines. And so the liver, is going to be coming from the small intestines into the liver. The liver is going to pick these out of the sinusoids. It can also put things back into the blood. Now, this blood coming from the intestines may also be full of pathogens. And so we're going to have cells to take out those pathogens. Then this blood is going to be trickling through the liver, and then it will end up leaving the liver. Then we're going to also have these cells that are going to be making the bile. So over here we have the hepatocytes. That's going to be making up most of the liver. Here we have a branch of the hepatic portal vein. Here we have a branch of the hepatic artery. And then both of these are going to be intrahepatic bile ducts. Now, both of these are going to be lined with cells. On this particular one, the cells were just falling apart as they made the slide. Now, bile is very important for the digestion of fats. Then of the liver, there's two distinctively different cells, the hepatocytes and the cholangiocytes. The hepatocytes, as we saw, make up 80% of the liver. They're going to be found everywhere. They make the bile. They're very important with carbohydrate metabolism, protein metabolism, detoxification. These are doing the work of the liver. We're also going to have some non-parenchymal cells, the sinusoidal cells. These are going to be the endothelial cells that are in the sinuses. Now, typically, endothelial cells will have tight junctions, but these don't, because we do want a free movement of chemicals from the blood and the hepatocytes because they're doing so much of that work. Comfort cells, those are going to be the macrophages that help to eat the bacteria. Hepatic stellate cells, these, we can't actually see those on the slides, but they're involved with making collagen. These can lead to fibrosis in response to liver damage, and they think that this is part of the process that can lead to actual liver cancer. The cholangiocytes, on the other hand, as we saw, that they are very different cells. They're going to be larger cells, and they're going to be found in those intrahepatic bile ducts. So just to review here on the slide again, here's the hepatocytes out here. here are the intrahepatic bile ducts with those cholangiocytes, and they're going to be very different cells than the hepatocytes. Now let's follow the flow of bile for just a moment. Again, the hepatocytes are going to be making the bile. The bile is going to enter these bile canaliculi and go to this intrahepatic bile duct. Notice the bile is following through its own channels. There's no mixing of blood and bile in the liver. And again, this bile is vital for the digestion of fats. So then we're going to follow this as it's leaving the liver. Just one more thought. See this purple over here? Those are the macrophages, or the Kupffer cells that are there eating the bacteria. So on this slide, we have many intrahepatic bile ducts, and those are going to be coded C22.1. They're going to be draining into larger and larger ducts. So we're going to have the right and left hepatic duct. These are also going to be called the perihilar ducts. Then this is going to be a common hepatic. We've got a common bile duct, the cystic duct, and the gallbladder. Now, interestingly, these perihilar ducts, the common bile duct, the cystic duct are all coded as C24.0. Heather's going to be then talking about the discriminator to help us localize the site of the cancer. One other comment here, the liver is constantly making bile and it's dripping through this bile duct, but we are not constantly digesting food. So we're going to have a sphincter that is found here as it goes into the small intestines. When we're not digesting food, the sphincter is going to close, and then when that closes, then the bile is going to back up into the cystic duct and back up into the gallbladder. So the gallbladder does not actually make bile, it just stores it. And this is why you can live without your gallbladder. Now, normally, when you do digest food, the gallbladder is going to contract and squirt out that bile into the bile duct and go into the small intestines. If you don't have it, then you just don't get that squirt of bile. So Heather is going to be talking more about the discriminators to localize a site of cancer.
Okay, before we dive into that C24.0 extrahepatic bile duct code and the site discriminator, I just wanted to take a step back and look at coding primary site with these different histologies. So going along with what Melissa just told us about the distinct differences between hepatocytes and cholangiocytes, this slide will make a lot of sense. So hepatocellular carcinoma is 8170/3 and is only possible in the liver. That's where those hepatocytes are found. This is a cancer of those hepatocytes. So that's C22.0. The cholangiocytes are found in the bile ducts. So cholangiocarcinoma 8160/3 is only possible in the bile ducts. So the site code is typically C22.1, that's the intrahepatic bile ducts, but of a side note here, 8160/3 is also valid in C24.0, the extrahepatic bile duct, per cancer path chart. Combined hepatocellular carcinoma and cholangiocarcinoma. This is coded to 8180/3. And it is not possible in the liver. So this should be coded to C22.1, intrahepatic bile ducts, regardless of where the biopsy was obtained. And this information is all in the solid tumor rules in table 9A. And then lastly, here we have adenocarcinoma, 8140/3. This was determined to be not possible in the liver. So the primary site cannot be C22.0. Okay, so we just heard that adenocarcinoma is not possible in the liver. So continuing on through the solid tumor rules, table 9A, we have the table laying out a site of biopsy, pathology results, some criteria, and then what the primary site and the histology would be. So if you do have a liver biopsy, the pathology result is adenocarcinoma or a subtype of adenocarcinoma. And we have supporting documentation such as scans, lab tests, or a definitive clinical diagnosis of intrahepatic bile ducts, or a definitive diagnosis of cholangiocarcinoma. Then the primary site would be coded to C22.1 intrahepatic bile ducts, and the histology would be 8160/3. This is as of 1/1/2023 and forward. Next, if we have a biopsy of the liver and the path result is adenocarcinoma or a subtype of adenocarcinoma, and there is no documentation supporting the primary site of intrahepatic bile duct in the medical record, and again, that would include in your scans, lab test, or definitive clinical diagnosis, then we do have to code the primary site to C80.9. The liver is a common metastatic site for other neoplasms, such as breast, lung, and colon. So they do instruct to code unknown primary site C80.9 when a primary site is not indicated in the path report or in the medical record. And of course, the histology is 8140/3. Okay, so continuing on with coding primary site, we are back to those extrahepatic bile ducts C24.0. So as Melissa told us, and as you can see here on this slide, the cystic bile duct, the perihilar bile ducts, and the distal bile duct are all coded under the site code of C24.0. So we do have the cystic bile duct. Again, this is what the gallbladder tapers into. So that is C24.0. And then perihilar or proximal cholangiocarcinomas that involve the main biliary confluence of the right and left hepatic ducts are coded to perihilar bile ducts. This is also, again, C24.0. And these tumors do comprise about 50 to 70% of all cases of bile duct carcinomas. And then the distal bile duct. So these tumors have their center located between the confluence of the cystic duct and the common hepatic duct and the ampulla of Vater. So with these sites all being coded to the same primary site code of C24.0 comes challenges, since there are different coding schemas and staging chapters for the cystic bile duct, the perihilar bile ducts, and the distal bile duct. So that's where schema discriminator 1 comes in. And it's very important to code this field correctly for the correct schema and chapters to pull up into your software. So as you can see here, codes 1, 5, 6, and 9 are all going to pull the perihilar bile ducts schema and chapters. So code 1 is pretty straightforward. That's perihilar bile duct, proximal extrahepatic bile duct, or hepatic ducts. Any of those indications of primary site, your discriminator would be set to 1. Okay, so codes 5 and 6 are where things get a little bit more detailed and require more of that investigation and critical thinking. And to be honest, these cases are usually, not as straightforward as just telling us that this is a perihilar bile duct or hepatic duct primary, and end of story. It does take that investigation. So code 5 is going to be used when there is diffuse involvement or more than one subsite involved and the subsite of origin is not stated. So we'll use code 5, and that will pull the perihilar bile ducts schema and staging chapters. If the tumor is stated to be in a middle extrahepatic bile duct and treated with combined hepatic and hilar resection, that's also going to be your perihilar bile duct schema and staging chapters, and we'll use code 6 in the discriminator to get those schemas and chapters to pull into the software. If we have extrahepatic bile ducts NOS, no other information, they just say it's extrahepatic bile ducts, and we cannot make a determination otherwise, we would use code 9. That's also going to be the perihilar bile ducts that will be pulled into the software. Now, if you have a statement of distal bile duct, or common duct NOS primary, then that is going to be code 4. And again, more straightforward. That's going to pull in the bile ducts of the distal bile ducts schema and staging chapters. If you have a statement of a middle extrahepatic bile duct and the patient was treated with a pancreaduodenectomy, then we will use code 7 in the schema discriminator. This is going to pull in, again, the distal bile duct chapter. Okay, one last thing I wanted to point out. When you have your schema discriminator 1 set to 1, 5, 6, or 9, because one of those criteria are met, and you definitively have cholangiocarcinoma 8160/3, your schema codes are going to pull up for the perihilar chapter as well as the staging chapters. Now, per cancer path chart, C24.0 and 8160/3 are a valid combination. However, the perihilar bile duct chapter in AJCC does not include 8160/3, so your case will not be stageable. That's okay. Leave it set to 88 for not applicable. We don't ever want to change the histology just to stage the case. That's very important to note. So again, make sure that you are not changing a histology simply to make a case stageable. Code the histology per the solid tumor rules. Okay, and that's all we have for you today. We hope you enjoyed this month's coding break, and we'll see you back here next month for a live coding break on decoding the details, a deep dive into grade and site-specific data items. Make sure that you do have your grade and site-specific data item manuals ready to go. This will be a polling kind of trivia type format, and we are going to get into all of the kind of common coding pitfalls and advanced nuances to really help to improve your data accuracy and consistency. So we hope to see you there. Thank you.